So this is indeed the last and the ninth and final video on contraception. I really hope you enjoyed this week on contraception on the channel and you learned a lot on contraception because it's a topic that many people often tend not to really understand. Grab a piece of paper and let's go. Hello and welcome to MK's Medical Review Series. My name is Dr. Moses Kazevu. This is a series on my YouTube channel where we look at medical topics in depth. Today we're going to be looking at permanent contraception. In the preceding videos, we looked at contraceptive basics, the oral contraceptives, the transdermal and vaginal ring hormonal contraceptives, injectable contraceptives, implants, intrauterine systems and devices, barrier pericoital contraceptives, fertility awareness methods. We looked at emergency contraceptions. And in this video, we will look at permanent contraception. Coming back to our basics, remember that contraception is pretty much the intentional prevention of conception through various devices, sexual practices, chemicals, drugs, or surgical procedures. We talked about the different classes. We talked in detail about the hormonal-based contraceptions. We talked in details about the non-hormonal-based methods. And in this lecture, we will talk about the surgical methods, predominantly vasectomies and female sterilization. So remember that in terms of permanent contraception, this is usually chosen by relatively older couples who are sure that they have completed their families. Most of the couples that actually are below the age of 30 that opt for permanent contraception, research has shown that they tend to regret later on in life. So if a patient comes in and opts for this and they're quite young, you want to counsel them and give them all the information and maybe offer them an alternative method of contraception. Remember that occasionally individuals that have no children or who, for example, carry an inherited disorder may choose to be sterilized. Vasectomy is easy, cheaper, and slightly more effective than female sterilization. It does not require general anesthesia, and the semen analysis has to be checked after the procedure to ensure that it has been successful. Sterilization procedures are actually quite very effective, and pregnancy rates at 1% are going to be around 0.15% with vasectomy, as well as 0.6% with the fallopian tube permanent contraceptive procedures. And remember that sterilization is intended to be and should be permanent, so there is no reversal. But in some cases, if the pregnancy is desired, a reversal procedure may be considered, but live birth rates after such procedures are as follows. After a vasectomy reversal, it's about 26%, and after tubal sterilization, a small percentage when the tubes are closed, and 0% when the tubes are removed. So in vitro fertilization must be used. Remember that individuals should not have sterilization procedures if they feel that there is a chance that they are going to one day want to have kids or one day want to have it reversed. So regret actually is very common, especially like I said, in individuals that are less than 30 years at the time when they come and those that have no children or women who are within 1 year of delivery. So long-acting reversible contraception is actually a highly effective and an option that you may offer to these patients as not giving them the permanent contraception or cancelling them out to opt out of the permanent contraception. Remember, in women, successful reversals depend on certain things. For example, a patient's age, the type of tubal procedure that was done, the amount of scarring in the pelvic area, and a fertility test results in a woman and her partner. Surgical methods work by blocking the sperms from reaching the eggs. And remember, it's essential that individuals are carefully counseled before sterilization and they should give written consent. And consent forms should be clearly indicating that the permanent methods or these sterilization methods are permanent and sometimes they do fail. This is one point that most people don't understand, is that you get people taking you to court or people suing you because you didn't counsel them adequately enough. You must also tell them that these methods can also fail. It doesn't mean they are 100% are going to offer you contraception. They are quite effective, yes, but they do fail occasionally and a patient eventually gets pregnant. And both partners must be present at the time of the counseling session and they must both sign the consent, including the surgeon that's going to be doing the operation. Because the failure of sterilization and vasectomy, this is a major area for medical litigation. So we'll begin with vasectomy. Remember that this is a procedure where you're going to be cutting the vas deferens and the cut ends are going to be ligated or fulgurated. then the vasectomy can be done in about 20 minutes under local anesthesia. The sterility actually requires about 20 ejaculations after the operation and should be documented by 2 sperm-free ejaculates, usually obtained 3 months after the operation, and backup contraceptive methods must be used until that particular time. There may be mild discomfort for 2 to 3 days after the procedure. Then you should just advise them to take some non-steroidal anti-inflammatory drugs, and they should not attempt to ejaculate during this period because it's not recommended. Complications of vasectomy include hematoma in less than 5% of the patients, sperm granulomas, which is an inflammatory response to sperm leakage, and this may need surgical excision, spontaneous reanastomosis, which usually occurs shortly after the procedure, and some chronic scrotal pain, which is uncommon in a third of the men that will have pain at 12 weeks post-vasectomy, but only about 6 to 8% of men will still complain of significant discomfort at the end of 1 year. And remember that some men will develop anti-sperm antibodies after the vasectomy. These are not going to be causing much problems unless if the vasectomy is reversed, then pregnancy may not occur because these antibodies are going to inactivate the sperms. And over the years, there is a possible association between vasectomy and the development of both prostate and testicular cancer. And this actually has been raised widely in the media, but clinical data and in practice, there is insufficient evidence to support the association. The cumulative pregnancy rates are about 1.1% at 5 years after vasectomy. So here are the different techniques of vasectomy. You may have ligation or clips, which is most commonly used. You may sometimes use unipolar diathermy. You may have excision, which allows for histopathological confirmation to ensure that you have indeed cut the vas deferens. You may have the no-scalpel vasectomy, which are widely practiced in China, where you use special instruments to puncture the skin, and there's a low incidence of complications. You may sometimes use silicone plugs, sclerosing agents, which are also used in China, and they also avoid having a skin incision. And in terms of tubal sterilization, remember that this is going to be involving mechanical blockage of both fallopian tubes to prevent sperm reaching and fertilizing the oocyte. It can be achieved by hysterectomy as well, or total removal of both the tubes. And remember that female sterilization will not alter the subsequent menstrual patterns because the ovaries are still there. And as such, if the woman actually stops the combined pill to be sterilized, she may find that she has a subsequent period that is actually much heavier. And alternatively, if she had an IUD removed at the time of sterilization, she might find the subsequent period actually to be much lighter. For tubal sterilization, the fallopian tubes may be cut and the segment it can be excised. They may be closed by ligation, fulguration, or various mechanical devices such as plastic bands, rings, spring-loaded clips. It may be completely removed. You may have these pregnancy rates that are higher with the spring-loaded clips than with the plastic bands. Remember that the procedures that use mechanical devices cause less tissue damage and thus may be more reversible than closure by ligation or fulguration. Then the complete removal of the fallopian tube is actually associated with 40 to 50% reduction in the risk of ovarian cancer. Remember that postpartum permanent contraception has a lower failure rate than the interval procedures. Remember that the following procedures can be used. You can have a laparoscopic procedure, which is used for internal procedures after postpartum period. You may have a mini laparotomy, which is used for the postpartum periods or procedures. And remember that this is a procedure of choice postnatally when the uterus is actually enlarged and it's actually much more vascular. The tubal ligation can be done during cesarean delivery, but there's a higher risk of mortality because it's like you're doing 2 procedures in once. And of course, the uterus is much more vascular than the person that's not pregnant. But remember that the tubal ligation can be done during cesarean delivery or 1 to 2 days after vaginal deliveries via a small periumbilical incision. That's what we refer to as a mini laparotomy. The techniques include clips, which are used in UK, and there are several types that are available on the market. Occasionally, they may not occlude the whole tube. You may use fallope rings, which are easy to apply. They damage about 2 to 3 centimeters of the tube and therefore making subsequent reversals more difficult. You may use ligation, which is suitable for postpartum mini laparotomy, and this has a relatively higher failure rate, but we do use this in our setup here, what we call bilateral tubal ligation, or BTL in short. You may also use electrocautery or diathermy, which may damage the surrounding structures such as the bowel and the bladder. There's a relatively higher late failure rate. And you may use Ensure, where this is inserted via hysteroscopy under local anesthesia, and it's going to be these expanding metal springs that are placed into the fallopian tubes proximally. You may sometimes use some chemical agents that can be inserted via laparoscopy, or rather hysteroscopy under local anesthesia. They are not available in the UK, but they are used much more widely in Asia. In terms of permanent contraception by laparoscopy, remember that these procedures are going to be used to provide permanent contraception for women that are done as an interval procedure that's unrelated to pregnancy and usually at least 6 weeks after delivery. And they can be done in the operating room, and they're done under general anesthesia. Remember, the cumulative failure rate of these procedures is roughly about 1.8% at 10 years. However, certain procedures have a higher failure rates than others. In terms of the permanent contraception by a mini laparotomy, remember that this is sometimes used instead of the laparoscopic procedures. This is what we use in our setup here, and it's usually done when women want permanent contraception soon after delivery of a baby. The mini laparotomy requires general, regional, or sometimes local anesthesia, and it's going to be involving a small abdominal incision about 2.5 to 7.6 centimeters and removal of a section of the fallopian tube. And compared with the laparoscopy, the mini laps are going to be causing more pain and a slightly longer recovery time. In terms of the permanent contraception by hysteroscopy, remember that this is going to be done was done in the early 2000s, and the hysteroscopy is actually placed where you actually insert these coiled micro inserts into the fallopian tube, and this can be used to provide permanent contraception. And as of December the 31st in 2018, the devices used in this method were actually removed from the market. Therefore, this method is no longer being commonly used. The coils that are used for hysteroscopic sterilization are going to be consisting of an outer layer of nickel or a titanium alloy and an inner layer of stainless steel or the polyethylene terephthalate. Then the PET fibers that are inserted into the fallopian tubes are going to stimulate an ingrowth reaction that is going to be occluding the tubes. Remember, unintended pregnancy rates are similar to those that are with hysteroscopic and laparoscopic permanent contraception. If the patient actually is having an ongoing pelvic pain or vaginal bleeding, the micro-inserts actually have to be removed. And remember that typically the micro-inserts are inserted, or rather are removed via the hysteroscopy, but laparoscopy actually may be required if the part of the micro-insert is actually outside the fallopian tube. Complications include the following things. You may have anesthesia-related complications, but remember these complications with tubal sterilization are actually quite uncommon. There may be death in 1 to 2 per 100,000 women. There may be hemorrhage or intestinal injuries in about 0.5% of women. They may have other complications such as failure of tubal occlusion in up to 5% of women. Then ectopic pregnancies in about 30% of pregnancies can occur after tubal occlusion. And complications of permanent contraception by hysteroscopy may include things like pelvic pain, abnormal uterine bleeding, as well as inflammatory disorders. I really hope you enjoyed Contraceptive Week on the channel and you learned so much. If you did, consider dropping a like, dropping a comment. It does show some support and it goes a long way in the YouTube algorithm. Do not forget to hit the subscribe button, hit the bell notification icon to be receiving notifications of such amazing content every time I post. To Zambia and beyond, my name is Dr. Moses Kazevu. Until next time, bye-bye.